welcome, and I apologize, Dr. Chemaly.
No, thank you. And sorry about the change, because I have the right to catch to go to the airport, and we're a little bit behind schedule. So it was safer to get started with the session, and then Dr. Alousi can take over. Thank you for the organizer for having me here. We're going to switch gear now. More interesting topic about infection, right? And it's amazing what's going on in your field, and we barely can keep up with all these new drugs, all these new strategies they're doing when it comes to infection and what to do, how to prevent, how to treat. So it's like, try to keep up with you all. That's what I've been telling my friend and colleagues at MD Anderson. But it's been a really very exciting time for all of us, it looks like, for our patient mainly, but also for us in a way that we want to do whatever it takes to keep your patient alive, to prevent infection, or to treat infection, to be pre-aggressive from the beginning in order for them to go ahead and continue the treatment and impact their outcome when it comes to underlying malignancy. So this is we changed all the topic like every speaker. There's no way I can talk about infection in 15 minutes. It's gonna take me probably 2 weeks, but I can talk about some advancements, some viral infection. And this is my area of research, and these are my disclosures. But this is what I'm gonna focusing on. This is where we had some headways when it comes to cytomegalovirus. That's what I'm gonna focus on, and what we accomplished over the past 2 decades, and where we at, especially in allogenic stem cell transplant. We had also lots of work going on with the CAR-T, but I don't have time to cover that topic. And at the end, I will talk a little bit about respiratory viral infection, and also I picked 2 viruses, which are RSV and parainfluenza, and where we at, and at the end, give you some of my final thoughts, where we're heading. And for any type of patient with hematologic malignancies, but mainly transplant, that's where we focus in CMV. But looks like it doesn't happen only after allotransplant. If you look for it, you're going to see it in any other patient with myeloma, lymphoma, CAR-T or not, or other targeted therapy that you may see, but what to do about it. That's what we're trying to define and to make it clear and try to collect data and see what we should do, what's best for our patient. Now, the major advances in CMV management, at least over the past 3 decades, we conducted so many trials, but we were lucky or were successful around a few years ago to have something going on and something really with improved outcome. Let me start first with the diagnostic tool that we have. As you all remember, probably older generation, when we used a shell vial or when we used to use CMV antigenemia. We moved away. I hope that everyone moved away from that. Now we have much more sensitive tests, which are the molecular assays. But also, they are very sensitive assay. Sometimes it's not good because are we over-treating or not? Probably we are. But at least that's a good advancement. We can catch any reactivation pretty early on. But what's more exciting as well is looking at CMV-specific T-cell responses. How can this guide us in order to manage this patient? Would I treat if they have low-level viremia? Would I put them on prophylaxis if they don't have good T-cell response or reconstitution after allotransplant? And many other questions that we may not have answered unless we run this specific CMV cellular-mediated immunity. And we have lots of data. We published quite a bit on it. And stay tuned. We may have some kind of guidance. I won't call it guidelines, what to do at least after allotransplant. But still, I don't have time to cover that. But this is what I like to say about it. Now, what is more interesting is prophylaxis. For CMV, as you all probably that we have a new drug which was approved in 2017 to prevent CMV reactivation or disease after allotransplant in recipient positive, which is letermovir. I think this is a big success story, and I'm going to show you some data and tell you why that, at least to prevent. But also, we're lucky in 2021, or we're successful in 2021, after multiple trials, we had another drug, which is maribavir, that can manage patient with resistant refractory CMV infection. I'm talking about very serious infection in very sick patient. But the patient who get this kind of infection are pretty heavily immunosuppressed patient, heavily treated, multiple line of therapy for their underlying disease, and they end up with a big problem with CMV if it was not prevented. So maribavir. So I'm going to talk a little bit quickly about that. So this is what's been going on in the CMV world. Few new drugs. Letermovir, we talk about different mechanisms of action than the regular drug that you are all familiar with, ganciclovir, foscarnet, or cidovovir. Very toxic drug. Does it work? Yeah, but very toxic drug. It limits the use of this drug, and they have the same kind of mechanism of action. At the end, they inhibit DNA polymerase of CMV. Now, the new drug, letermovir, work on the terminus complex of CMV. Later on in the DNA elongation of the CMV, but there's no cross-resistance. And this is the one we use for prophylaxis. Maribavir, it inhibits UL97. The enzyme that's needed to phosphorylate ganciclovir. That's why it's a no-no. We cannot use ganciclovir and maribavir in combination because it could be antagonistic. So kind of different, mechanisms of action, but there is cross-resistance between maribavir and ganciclovir. Specific mutation, specific codon can, confer resistance to both. The other drug, cidovovir, that you probably heard about it many years ago. We conducted probably at least 5 to 6 trials. Were unsuccessful to bring it to the market for prevention of CMV infection after transplant for many reasons. I'm not going to get into that. Then we tested in adenoviral infections. Also, we were not able to do that. Now, we were lucky enough to convince people who took brincidovir, a new company from Japan, Symbio, to test it not only in adeno, because there's still big unmet need in CMV in our patient population, but for CMV. We have a phase 1b trial looking at dose escalation that almost done with the 2 level. We have the 3rd level, and hopefully, if it looks good, then we can move it into phase 3 trial to treat preemptively CMV infection and also to treat resistant refractory CMV infection. So this is something to stay tuned to, and it may occur later on in the future. Let's talk about letermovir and why it was a success, a big success story. We conducted the phase 2 trial before 2014, and dose escalation, we found out that 240 milligram, it will prevent CMV reactivation, what we call clinically significant CMV infection, with not much of side effect, oral, and we have it also in IV formulation, pretty safe. We moved to the phase 3 trial, which also showed that it had a big impact when you compare prevention, which is letermovir, versus placebo, which is kind of preemptive therapy. And there was big difference in outcome when you look at clinically significant CMV infection. But what is more interesting, we start seeing, based on this first phase 3 trial, there were difference in all-cause mortality. When you're on prophylaxis versus preemptive therapy, you have more patients dying or when they are on preemptive therapy, and they didn't die from CMV disease or from CMV. It's all from the indirect effect of CMV. So it prevents reactivation. You may impact all-cause mortality after allo transplant in recipient positive, which is very interesting. And then CIBMTR published more than 9,400 patients looking also at this outcome, and they found the same thing. That you have lower non-relapse mortality and lower all-cause mortality when you prevent viremia versus if you allow the virus to reactivate. So said, okay, maybe this was an exploratory endpoint in the phase 3 trial. Maybe it's not true. But we're interested, after we start using it for many years, is it true in real-world use of letermovir around the world? So we put together, at that time when we did this meta-analysis, we found 48 studies from all over the world. Most of them were from the US, looking at CMV outcome. It was true, yes, letermovir prevented CMV reactivation, clinically significant CMV infection, but also CMV and organ disease. But we were more interested to look at other outcomes. What about all-cause mortality? Yes, it was true. Beyond day 200, they had less patient dying if they received letermovir versus the patient who did not. Less non-relapse mortality as well. Also, there were some trend data for GVHD, but the data was not that strong, and CMV-related hospitalization. So this was the impact of letermovir over the past many years of using it in real-world data. But the other question came up, actually, which is interesting. We know for years, for the past 20 years, any recipient positive is a disadvantage of all-cause mortality or survival compared to recipient negative. By being only recipient positive from the get-go, before transplant, they have lower overall survival than the recipient negative. And this is the indirect effect or the direct effect of CMV infection. So the question came up, and actually we tried to answer it in our database. Did we close the gap now with letermovir? If we prevented CMV in recipient positive, do we have the same mortality compared to recipient negative? And this is the data that we published recently, looking at more than 1,071 allotransplant patients, 940, out of this 940, some were on letermovir, some did not receive letermovir. It was a preemptive therapy before the era of letermovir. Compare the control group, the D-, R-, and we found, yes, patients who were on letermovir, they had the same all-cause mortality than D-, R-. Patients who were not on letermovir for any reason, and they got preemptive therapy, they had higher mortality, all-cause mortality, compared to the D-, R- and to the one who received letermovir. Same thing for non-relapse mortality at the same time. So even we close the gap. So I think, do you know any anti-infective drug that can impact all-cause mortality? I'm not talking about bacteremia you treat. If you don't treat, they die from an infection or septic shock. I'm talking about preventing one viral infection. It impacted, all-cause mortality. And I think this is a great outcome that we accomplished over the past many years by using prophylactic regimen. Now, what about CMV resistant? We know it's not that common after allotransplant, but it may happen. Refractory without mutations in the viral codons, it's much more common before the era of letermovir. Now with letermovir, we showed that even resistant refractory incidence went down, but still we can encounter this, especially now when we have much sicker patients. And we can tell when we run on the stem cell transplant team, on the lymphoma, myeloma, leukemia, we are dealing with more heavily immunosuppressed patients, multiple line of therapy. Now you keep them alive for a long period of time to go on investigation drug. Before we didn't do that, they were be dead before they get to us. But now they are admitted because of all the complications. So we're seeing weird infection. We see very heavily or difficult to treat infection, not only viral, fungal infection. Well, we're seeing rhinocerebral. I have like 3 or 4 on my service in lymphoma and myeloma service. You see all this weird infection now. So we want to make sure, how can we prevent, how can we do better job not to get to the stage of end organ disease. So for CMV resistant, we know the commercially available drug that we had for years, very toxic drug. You're all familiar with nephrotoxicity, myelosuppression. We don't want that. And we know the impact of resistant and refractory. If you look at end organ disease, if you have refractory resistance, they have higher incidence of end organ disease, and they have the lower survival as well. So it's not good to get to this point in our patient population. Big unmet need, and it has to do with the toxicity of the drug as well. So we need a new drug. And that's why, maribavir, it was tested early on for prevention of CMV. It did not work. But what about treating resistant and refractory? We conducted the SOLSTICE trial comparing maribavir to investigator-assigned therapy, and and the primary endpoint was CMV clearance up to, on 2 consecutive tests after stopping the drug, which is at week 8. Compared to the investigator-assigned therapy. And what we found here, the big difference in clearing CMV viremia at week 8 if they got maribavir versus if they got other drug like ganciclovir, foscarnet, or even combination therapy. And we stopped the drug. At week 12, we had lower, less patients who achieved clearance, but more than the assigned therapy in this patient population. So it was a positive trial and got approval for adult or 12 years of age and above to treat resistant or refractory CMV infection. It's an oral drug, safe drug, and safer than the other ones. Actually, I have data on side effect of these drugs. When you compare both, foscarnet is more nephrotoxicity, and ganciclovir more myelosuppression. Okay, let's shift here and talk a little bit about respiratory viruses. We know a huge burden of respiratory viruses. I'm not talking about only COVID-19 or SARS-CoV-2. Different story, don't have time to cover for that. But what about RSV? What about influenza? What about para-influenza? We know it can cause, it can increase mortality and patient may die from respiratory failure. And there's many specific risk factors. We look for it when we treat these patients, if we have something to treat this patient. And these are the ones that you are familiar with from lymphopenia, hypogammaglobulinemia, and other risk factor as well. That's how we used to treat RSV, high-risk patient after allotransplant in our institution and many other institutions, put them in a tent, give them aerosolized ribavirin. We knew that it wasn't really the best strategy, and we didn't know if it worked or not. There were no randomized trial, all based on retrospective data or prospectively collected data comparing aerosolized ribavirin versus nothing. And we know, and we know that it worked, but I will show you the data later, but it's not a magic drug or magic bullet. But aerosolized ribavirin, admit patient, put them in the tent for 10 days to 2 weeks, it doesn't work. We don't have much going on for RSV as a treatment. Palivizumab, a monoclonal antibody, doesn't work when you have established disease. RSV, hyperimmune, IVIG also at the same time. But, and there's a new monoclonal antibody not tested in immunocompromised patients. Monoclonal antibody, keep in mind, for infectious reason, early, better than late. Late doesn't work usually. Early young for prevention, or maybe for early infection, it may work as well. But we know, based on a systemic review and many retrospective collected data, that there is a difference in outcome when you look at progression to pneumonia if they got aerosolized ribavirin or oral ribavirin versus they don't get anything. And this is pretty old review that we did, but also mortality. First time to show that there is impact on mortality as well. And this is one of the largest study that we published on RSV. Same thing, if they receive antiviral, less progress and less die from RSV. And this is high-risk patient as well. Now, aerosolized ribavirin, we know it doesn't work. It worked, but it's not going to cut it. And then all of a sudden in 2015, the cost went up by 300%. Used to cost maybe 3,000 to 4,000 a day, and then the whole course costs around 300,000. So I said, you know what? There's no way when we don't have real good data, to prove that it worked in our patient. So we moved to oral. Now we're using oral, and we went back to see, did we do a disservice to the patient with oral ribavirin? We found no, same impact on progression to pneumonia versus mortality as well. Now, so that's why it made it to the guidelines we published probably last year or 2 years ago, where in high-risk allotransplant, they have time to define which are high-risk based on a immunodeficiency scoring index that we developed at MD Anderson, where people are using it in all centers. If patient is high-risk for RSV or other respiratory viruses, they may get treatment or not, and this is recommended, ribavirin is recommended until we get a better drug. We conducted few clinical trials for fusion inhibitors. It turned out to be a negative trial, but still hope is there. There's few in the pipelines. Para-influenza, quick thing, also it affects outcome in leukemia patients, stem cell transplant, lymphoma, myeloma, more progress to pneumonia, but also mortality around 18% if they develop pneumonia from para-influenza. Good news, we have a new drug. We've been tested for the past few years, the S181 inhaled drug. It downgrades hyaluronic acid, which is needed as an anchor for some of the viruses, para-influenza, influenza as well. We did the phase 2 trial. This is the first one ever actually done for para-influenza in high-risk patients, but it was a negative trial. But what we found, if you target high risk only within 1 year of transplant, patient with lymphopenia, you see antiviral effect when it comes to clinical stability and mortality, a trend. So the FDA approved a phase 3 trial based on different endpoint, which is return to room air. If they were on oxygen with severe para-influenza pneumonia, you can put them on this drug and look at it. So we're almost done with the phase 3. We hope it is a positive trial, and then we'll see if we're going to get the first ever drug for parainfluenza in high-risk patients with severe pneumonia from parainfluenza. It's very common. It's not uncommon. We see it quite a bit, around the nation and everywhere. So my final thought, low-hanging fruit. We have a new tool to test for CMV stellar-mediated immunity. This will help us to manage patients at the bedside. DS-181 for severe PIV RTI. I didn't talk about pritelivir, another drug, different mechanism of action than acyclovir and valacyclovir for resistant HSV infection. Stay tuned for vaccine, RSV monoclonal antibody. Hopefully we'll have some trial going on. And there's another also modality, which is a immune modulator, can elicit adaptive immunity in the lungs, POL042. We're going to start a phase 2, hopefully by this month, actually, to treat respiratory viral infection before they progress to pneumonia. Thank you for your attention.
Thank you very much, Dr. Chemaly. Fantastic review of viral infections in immunocompromised patients. Next, we have Dr. Amin Alousi, who makes people immunocompromised. He's going to talk us about allogeneic stem cell transplantation and advances in stem cell transplant. So, Dr. Alousi, happy to have you up here. Please put the appropriate slides.
Okay, while we're getting the slides up, thank you, Dr. O'Donnell. Thank you, my friend and esteemed colleague from MD Anderson, Dr. Tapan Kadia, for inviting me. A big thank you from Madison for all her great help with getting this on. So I promised Tapan I would keep this to 15 minutes, and I'm going to do my best to do so. If I can advance the slides. Which way? There we go. Here are my disclosures. So what is new in hematopoietic cell transplantation? Obviously, so much to cover in so little time. We're trying to make transplant safer in all the ways shown there. We're reducing relapse or trying to, and have research targeting reduction in relapse through those efforts. We're studying special populations, patients who have non-malignant diseases, older age transplant recipients, and looking at health disparities. So I can't cover all those topics today in 10 minutes, so I'm going to focus the area, albeit I'm a little bit biased towards GVHD, but the area where really some of the biggest advancements have happened in the past decade and two in terms of making transplants safer for our patients. So here we see the pivotal trial from the early 2000s looking at peripheral blood versus bone marrow graft source for match-unrelated donor transplant recipients. This was done by the BMT CTN. It was the first trial in our network. And all patients received the standard of care, tacrolimus, a calcineurin inhibitor, with methotrexate. And you can see 50% of our patients or so developed chronic GVHD. Fast forward to the modern era, and many of us believe this approach is paramount to malpractice, and we can do better for our patients. So how are we doing better for our patients with regard to prophylaxis from GVHD? Well, there's three backbone approaches. There's the calcineurin inhibitor, tacrolimus, cyclosporin in combination with short-course methotrexate, post-transplant cyclophosphamide. This is where you give cyclophosphamide on the third and fourth day after transplant, followed by tacrolimus and with or without mycophenolate. And this was work that dates back to the 1960s in murine and dog models showing cyclophosphamide was very effective in GVHD prophylaxis. And fast forward to the 1990s and early 2000s when colleagues at Johns Hopkins began to show that giving post-transplant cyclophosphamide followed by tacrolimus could overcome HLA disparity, and we can now do mismatch or haploidentical transplants using this backbone. So this has just taken off in the past few years, and increasingly at many centers, including my own, we are now using post-transplant cyclophosphamide, not just in the haplo setting, but in match-related and unrelated donors, and in fact, that's our standard of care at our center. Some retrospective single-center reports have raised questions about possible toxicity with this approach, cardiac toxicity from cyclophosphamide. There's some retrospective single-center analyses that suggest maybe you have weaker graft function and problem with counts when you use cyclophosphamide in this fashion. Some data to suggest maybe higher infection rates. And so there are still some concerns about toxicity with this approach. Finally, the third backbone is graft manipulation. So we know that it's the mature T cells in the graft that results in graft versus host disease. And so in the 1990s, depleting the graft of these T cells or selecting for the CD34 stem cell component was adopted. This requires some expertise and it's very costly. Some centers, notably Memorial Sloan Kettering, was a really big pioneers in graft manipulation with CD34 selection. But those T cells are also needed for the GVL effect, and so there's concerns with this approach as regard to maybe higher relapse. And then those T cells are also vitally important for early immune reconstitution in our transplant recipients. And so these patients are profoundly immune deficient, and we see numerous opportunistic infections. So how can we improve upon this in 2024? Well, using the TAC methotrexate backbone, you can add a third drug. Commonly, especially in Europe, in vivo T cell depletion with ATG is used. More recently, abatacept, co-stimulation blockade, CTLA-4 agonist, was studied, added to the backbone of TAC methotrexate. In fact, abatacept is the only agent FDA approved for the prevention of GVHD, and this came to be through the ABBA-2 trial, where this was a randomized trial in match donor recipients. They've received either placebo or 4 doses of abatacept in combination with calcineurin inhibitor and methotrexate. And in randomized trial, this reduced the day 100 cumulative incidence of grade 2 to 4 acute GVHD, but importantly, it had no impact on grade 3 to 4 severe acute GVHD, no impact on chronic GVHD, didn't lower non-relapse mortality, and it didn't improve survival. And because of that, despite being FDA approved, this has not really been broadly applied across centers. People are looking at extending abatacept dosing to mitigate against chronic GVHD. They're looking at giving abatacept with post-transplant cyclophosphamide, and that is ongoing research that hopefully we'll have answers to in the next upcoming years. Okay, turning to post-transplant cyclophosphamide, is this the standard of care? Well, certainly in the reduced intensity conditioned recipients, there's good evidence to suggest it may be. This is the results of our 1703 trial. This was a randomized multi-center phase 3 trial comparing tacrolimus methotrexate versus post-transplant cyclophosphamide, followed by tacro and mycophenolate. In patients who received reduced intensity conditioned allotransplants from peripheral blood stem cell source. The primary endpoint for this trial was GVHD-free, relapse-free survival. To meet this endpoint, you could not experience grade 3 to 4 acute GVHD, could not have chronic GVHD needing treatment, relapse, and of course you had to be alive. And the trial was positive for this primary endpoint, much more likely to have Griffiths when you received post-transplant cyclophosphamide than TAC methotrexate. And this largely was because it was successful in reducing grade 3 to 4 acute GVHD, bringing it down from 15% to 6%, less chronic GVHD, a third of the patients down to 20%. It did not do this at the detriment of relapse. There was no difference in relapse rates between the arms, and there was a non-statistical trend for improvement in survival, 77 versus 72%. So at this past ASH, knowing that this was a trial mainly done in older patients who are appropriate for reduced intensity, the question was raised whether, maybe, since a quarter of the patients roughly were over the age of 70, if cyclophosphamide is too toxic, we would see it in that population. And the hypothesis was that maybe in that population, post-Cy is not the right answer. And here's the results of that trial, and it was quite surprising, or the results of that analysis. So in patients 70 years and older, consistent with the primary results, Griffiths was better in those patients than those who received post-Cy versus TAC methotrexate. But more importantly, and this is outstanding, overall survival was better in those patients 70 years and older who got post-transplant cyclophosphamide. I mean, it's crazy to think that the overall survival rate at 1 year in patients who got post-Cy who are 70 years and older was 90%. I mean, when I started in a transplant 22 years ago, you couldn't imagine getting a 70-year-old patient, with that type of overall survival rate. And it was statistically better than those who got TAC methotrexate. This was because TRM was markedly low with post-transplant Cy, and there was no indication that Cy increased infections nor increased cardiac toxicity. So really, if you're going to see toxicity with the cyclophosphamide, certainly you would see it in patients 70 years and older. So what did we know from this analysis presented at ASH? Well, post-Cy should be considered the standard of care in patients 70 years and older. And this high survival rate seen with post-transplant cyclophosphamide should really encourage greater consideration for allotransplant in this older age population with hematologic cancers. So what other strategies are being done to see if we can tweak post-Cy and even get better results? Some are looking at the feasibility of giving lower doses of cyclophosphamide. At Mass General, across the board, instead of giving 50, they give 30 times 2. Some data suggests that may have improved outcomes. In Europe, they give ATG in combination with cyclophosphamide. Some data suggests maybe chronic GVHD rates are even lower. The addition of the JAK1/2 inhibitor, ruxolitinib, has been given as additional prophylaxis following post-Cy and has some really encouraging results. I'll show an abstract of that in a second, and it's actually shown here. So this was results from a trial conducted at Medical College of Wisconsin. My friend and colleague Mehdi Hamadani was the PI in this trial. And in this trial, they reduced the dose of cyclophosphamide from the traditional 50 times 2 to 25 times 2, so cut it in half. And they then gave mycophenolate and tacrolimus and started ruxolitinib 5 milligrams twice daily once the patient engrafted, and gave it for a year. Now, the results of this trial are premature. Their follow-up has been short, and not all the patients have been enrolled, but there's very, very low rates of acute GVHD and severe acute GVHD. Really can't comment on chronic GVHD with the degree of follow-up at this time, but encouraging results. All right, finally, in the last few moments, what about how can we improve upon graft manipulation? What do we know about historical CD34 depleted transplants? Well, this was results of another BMT-CTN trial. It was a 3-arm trial, and one of the arms was CD34 selection or T-cell depletion. And this is very effective at reducing graft versus host disease, both acute and chronic, to the single digits for both. But despite that reduction, overall survival is worse with CD34 selected transplants. And mainly this is because of infections, and it's because of toxicity associated with that approach. You need to get very intensive conditioning regimens to get the graft in, and outcomes as shown in this randomized trial was worse with that approach. So how can we improve upon that? Well, ORCA-T has been the strategy of late to do this. This was work done by Robert Negrin and colleagues at Stanford, and they commercialized this into a company where they said, okay, T-cell depletion, CD34 selection doesn't work, but how about further manipulation of the graft. So with ORCA-T, you collect the graft from the donor, and that graft are the progenitor cells and stem cells, of course. There's conventional T cells, regulatory T cells, NK cells, dendritic cells, etc. And with the ORCA-T approach, they do a CD34 selection and collect that and set it aside. And they separate out the T cells and they collect the tolerizing regulatory T cells and then the conventional T cells. And with this approach, following ablative conditioned transplants, and it should be pointed out the donor is collected 2 or 3 days before the transplant. The cells are sent to a central manufacturing facility at the company site, and in 2 days you get the cells back. The cells are, the stem cell graft is infused on day 0 along with a component of the regulatory T cells, and then 2 days later you infuse the conventional T cells. And this approach has been done. Patients go on to receive tacrolimus. It was studied first in a single center at Stanford and then in a multi-center phase 1 trial. And it showed really encouraging results. Low rates of acute GVHD, 4% severe. Low rates of chronic GVHD, just 5%. Unlike traditional T-cell depletion, serious infections were very uncommon. And there was really low non-relapse mortality, 4% at 1 year, and no evidence of higher relapse. So this is currently being tested in a randomized phase 3 trial. Standard of care arm is receiving the traditional TAC methotrexate following ablative matched donor transplant. So some have said, okay, well, the standard care arm in that randomized trial is TAC methotrexate. We believe this to be inferior. How would outcomes compare when you compare it to post-Cy? And so at this last year's ASH, that question was answered, comparing it to ORCA-T, the patients enrolled on the multi-center phase 1B trial, compared to the registry. The details that they presented were not that granular, but overall survival seemed favorable with the ORCA-T compared to registry patients who are matched. And just some hints that maybe ORCA-T can even outperform post-transplant cyclophosphamide. Just in the last few seconds, getting away from GVHD prophylaxis, there was a great abstract presentation looking at multi-center analysis of looking at socioeconomic factors as predictors for patients who will get transplant, who gets a transplant, as well as outcomes. And it was fascinating to see that these socioeconomic factors highly predicted for likelihood of getting a transplant, but when patients got a transplant, the outcomes were comparable. So really interesting work. There was another trial, results from the CHARM trial. This was looking at predictive models in patients who are older age getting an allogeneic transplant. And this trial showed that there was a tool looking at composite factors could predict for disability in older age patients undergoing allogeneic transplant. This is important because while we, of course, all fear death and complication, fatal complications following transplants, what older age patients often fear is being disabled and being a burden to their family. Finally, a transplant abstract looking at reducing relapse with maintenance chemotherapy post-transplant. This was work done at the Farber, where they looked at 2 dose levels of Incavi, either given days 1 through 3 or 1, 3, and 5 in combination with venetoclax, 400 milligrams daily for 14 days in a every 42-day cycle. 8 cycles were given. In general, the therapy was very well tolerated. Most patients completed the 8 cycles, although it was not uncommon for dose modifications to be needed due to cytopenias. With that, I think I'm very close to being on time. I thank you for your attention. And
All right. That was really wonderful. And now we are going to change, as we've talked about, the order of events just a little bit, and welcome Beth Faiman up. And she's going to do not one but two talks for us today, covering patient conversations, navigating complex cases, followed by addressing health disparities in hematologic oncologies. Thank you very much.
Thank you so much. Thank you, all of you who stayed, and even if you have to leave, that's okay too, because it's a long day. I'm Beth Faiman from the Cleveland Clinic, and in the next 20 minutes, will cover two topics. First, navigating complex cases, and then we'll dive into some disparities in hematologic cancers. So communication is definitely challenging, especially if you're managing multiple conditions. And here I have a case example of somebody I saw in clinic recently. This is a 48-year-old healthy male who worked full-time, no significant past medical history, went to PCP because he was feeling tired, had a hemoglobin of 10.3, went through colonoscopy, anemia studies, B studies, couldn't find anything, so he was referred to me for an IgA kappa paraprotein small M spike of 0.18. Felt fine, just tired. Thought he was tired because he had 3 kids under the age of 8 and was working full time. We reviewed the diagnosis of MGUS, what that entailed, and the plan to identify the underlying cause of his anemia. These are his labs. Notable for CBC diff, showed some anemia. He had a kappa-free serum of 15,000. So when they screened for MGUS with an SPEP, this was not captured. Notice at the bottom, he had 12% peripheral plasma cells. Remarkably, his serum creatinine was 1.8 okay. Calcium and albumin were surprisingly normal in this healthy guy, but he has now plasma cell leukemia. So now rapidly this conversation changed. It was, you have MGUS, it's very common, low level, but let's try to find out what's causing your anemia, to now you need an immediate treatment for your blood cancer. And we all know in this room that there's this long and winding road of blood cancers, whether you have a pre-leukemia, CLL, or an MGUS predisposing you to possibly multiple myeloma, you can go through a series of remissions and relapses. Unfortunately, you might ultimately be refractory to whatever treatment you're given. Survivorship concerns are very critical to address at diagnosis and beyond. One of the strategies that many of us employ in our practice is shared decision-making. You saw this mentioned throughout the slides. We have bispecific antibodies, CAR T-cell therapies, lots of different drugs available, and how do you arrive at that decision? So as providers, we try to say, this is what I think is best for you, but really involving that patient in on the discussion is super important. There's 4 essential elements that include 2 participants, the healthcare team and the patient caregiver. Both parties share mutual information. They take steps to build a consensus, and then ultimately a mutual agreement is hopefully achieved. And numerous studies have identified that this leads to less decisional regret, increased provider trust, and increased adherence. Empathetic communication is another strategy when you're managing difficult patient cases, and that's defined as both responding to emotions and actively appreciating another's point of view. There are many different cultural and other factors that play into whatever patients want for them in terms of treatment or not treatment. Some people, like my patient, he says, can I just think about it or go home and take some herbs? You know, that was his first response when we started the discussion. And the answer is, that's probably not what's best for you, but let's circle back and talk about the diagnosis, et cetera. And we'll get to how we approach that topic in a moment. But empathy is not what you say, it's how you say it. And patients will always remember how you describe the diagnosis to them in the next steps. And it's a way for us to remain patient-centric. So my favorite strategy throughout the years, and I've been over 25 years in the myeloma space, is to use this ask, tell, ask nurse strategy for empathetic communication. So again, the nurse stands for naming, understanding, respecting, supporting, and exploring the emotion or the response to whatever you're telling them. But I first start with like ask, tell, ask. So for example, when we start our consults, I ask them, what do you know about why you're here today? And why am I seeing you? You tell the patient the plain language, what's important information to digest in small amounts, just the basic information, and then ask the patient what they are absorbing. Of course, in my patient example with this young guy who had some mild anemia and fatigue, we had to go through this whole thing, naming the emotion that we're observing. He was just shell-shocked. It was like the pathologist calls me, 12% peripheral plasma cells. He's on his way home, lives an hour and a half away, has lots of work to do when he gets home. So we had to go through that and using words like, I see that you're surprised by the diagnosis, and I am too. So unexpected news can be overwhelming, and just trying to recognize what he might be going through. Understanding what they might need, such as a little more information might be helpful. I'm not going to go into everything today, but let's just talk about what we need to talk about today. Additional staging information, additional scanning that might be required for us to get the right treatment for you to make you feel better. Respecting the patient, maybe they need a few minutes, maybe they need something to drink or a cool glass of water, making sure that you're respecting them in their space. And then supporting the patient. My patient was by himself and his wife was at home with the kids. So do we need to FaceTime somebody, bring them in on the discussion, and then can I get the social worker to come meet with you as well? And of course, exploring the concerns. In my patient example, young, healthy guy, now he has a very serious condition that we need to learn more about in terms of the bone marrow biopsy findings and imaging. But exploring their concerns, like we've discussed a lot today, and what are your concerns about next steps, and really just letting them absorb everything. Now, my scenario was more focused on a new diagnosis, but end-of-life conversations in the patient communication space can be very, very difficult. In hematologic cancers, it's hard when they don't have symptoms and they have chronic leukemia or CLL to bring in the palliative care intervention early, but multiple studies in numerous different conditions have shown that early palliative care intervention can actually improve outcomes at end of life. And so I think just starting the conversation about what you know about that prognosis and bringing in the palliative team, they might meet with them once or twice, not see them for a year or 2 or 3, but we talked about that winding road, and there might be critical periods to introduce them to palliative care at other points, such as relapse, etc. This is just a conceptual model I threw in there about the multiple conversations over time. This was published in New England Journal of Medicine last year, but it just is really talking about how you have these cycling conversations over time. Hopefully with an early to palliative intervention, you can have increased quality of life, decreased psychosocial stress, and improved facilitation of end-of-life decision-making. Now, in the interest of time, I won't go through these communication strategies. I'm biased to the ask, tell, ask nurse method because I've been using it for years, but this is just some communication strategies regarding prognostic awareness, which were highlighted in the New England Journal of Medicine paper last year. So cycling back to our case example, you just diagnose him with plasma cell leukemia, recognizing this is huge, like his whole life is going to change. And recognizing that, trying to employ that empathetic communication is one of those things that you can do. Finding a quiet room or a private room, and not my chart messaging him, by the way, you have cancer. I hear that all the time. Or you need to see Hematology, Oncology because you have a condition I'm worried about. Trying to talk face-to-face with them is really, I think, critical to successes in building trust down the road. I think I already went through this whole ask, tell, ask. Ask him if he wants to connect with somebody. What do you think you understand about what is going on here? And then telling them just the basic information. One of the things that I think is of critical importance is the multidisciplinary team. I have a PhD and I'm a nurse practitioner. That's my role in the team. So I also have physicians, pharmacists, social workers, financial counselors. I am fortunate to have all that support system. So why not bring them into the discussion? So in this particular example, I knew he was my 1 o'clock consult. We got labs in by 3 o'clock. He needed to come back, and we had that face-to-face discussion. And I told my nurse and my pharmacist and my physician that I work with 12 of them, but the one that was in the workroom with me, and I said, can we all work together to get this patient what we need? Because I had a full clinic. I still had lots of patients to see. So bringing in your team is really important. We implemented shared decision-making. You might not have a lot of options. We know 4 drugs up front for myeloma, anti-CD38, immunomodulatory drug, proteasome inhibitor, and corticosteroid is probably what most of us would recommend for this guy, but we still needed bone marrow biopsy information, imaging as well. And he might not have a lot of options, but is it inpatient versus outpatient? And we already talked about empathy and how important that is as well. So These are our key takeaways. Many hematologic cancers are not curable, but highly treatable. Patients will go through a series of remissions and relapses, but hopefully if we can keep patient-centered, empathetic communication up front, that will establish trust, decrease decisional regret, and enhance adherence. I shared with you my Ask, Tell, Ask nurse communication strategies, and just want to put a plug in for discussions about prognostic awareness to start at the beginning and then interject them throughout the disease trajectory. And of course, don't forget to document all of these discussions in the medical chart. So thank you for that. And since now I'm doing back-to-back presentations so I can get to the airport, we're going to talk about disparities in hematologic oncology. Sure is dry in here. Maybe it's the altitude. My voice is shaky because of the dryness. Anyhow, I don't think I need to tell this audience about how prevalent hematologic cancers are. The 2025 new estimated cases show that lymphoma is, surprise, the most common hematologic cancer. But if you tease out all of the different subtypes, actually multiple myeloma is number one. And that's why I do it. But anyhow. The deaths are from primarily leukemia as well. Unfortunately, we heard today about all of the advances in leukemias, lymphomas, myelomas that have been enjoyed in the last few years particularly, but those successes have not all been recognized by all different groups. So there are obviously biological, environmental, sociological, and cultural factors which interplay into whether or not people will have successful outcomes. So just going through the top three, myeloma, lymphoma, and leukemia cancers, myeloma is one of the heme malignancies with the greatest disparity in incidence, prevalence, and outcomes between African Americans, Hispanic, and white Americans. It's the most common blood cancer in African Americans, and the genome-wide association studies have identified some germline genetic variations with increased risk in African compared to European ancestry. Interestingly, some studies show that the differences in myeloma in African Americans may lead to lower risk disease, such as translocation 11-14 and some other 14-20, 14-16s, with many subtypes involving those translocation differences. Hispanic patients, unfortunately, are younger at diagnosis and have more advanced disease. This is just a slide, again, highlighting the disparities in the diagnosis, treatment, and outcomes. 2 times more likely African Americans are to have myeloma than the white counterparts, delayed diagnosis, less likely to undergo stem cell transplant, and are underrepresented in clinical trials, both African Americans and Hispanics. Slower gains in overall survival improvements. Again, we have this vast improvement in overall survival, and you'd think because they have better disease, they would recognize that improvement. Unfortunately, that's not true. So I stole this from my friend and colleague, Dr. Joe McHale. African Americans are less likely to receive the 4Ts, transplant, triplets, CAR-Ts, and trials. So being aware of this is a thing. When you see these patients in clinic, please try to offer them equal access to therapy. We know there are disparities in lymphoma and outcomes as well. Non-Hodgkin's and Hodgkin's lymphoma, again, similar to myeloma. The Blacks, Hispanic populations predominantly do not get the same care. We also saw the different somatic mutations in driver genes that are listed here that are more common in patients with African compared to European ancestry. In terms of leukemia, surprise, disparities exist there as well, higher in men versus women, and although overall survival outcomes seem to be improving, especially in acute myelogenous leukemia in the last several years, especially with all these great new drug developments, the different racial and ethnic groups do not get that benefit in some studies. So this is just a conceptual model that highlights the disparities in survival in the context of hematologic malignancies. This is from a meta-analysis that was recently published, I think in 2023, Blood Advances, that looked at the different education, access and quality, neighborhood, healthcare access, social community, et cetera, pretty much the social determinants of health. And this was in all hematologic cancers. And consistent with many other studies, this meta-analysis looked at and identified that lack of health insurance or having Medicare or Medicaid, receiving cancer treatment at a non-academic facility, low household income, low educational level, and being unmarried were big drivers to treatment outcomes. So additional drivers that were also highlighted in other areas, the healthcare system, systemic racism, we talked about the social determinants of health as well, implicit and explicit biases. I think of that in regards to clinical trials where you see somebody in clinic and you're like, they're not going to be a good clinical trial candidate because they never call when they need anything or they miss appointments. But having a conversation, establishing trust, opening the lines of communication is one major way that we can impact and hopefully overcome the lack of clinical trial representation. I always say, just ask, so don't have your biases of who's going to do good or not, just ask. So what are some barriers and recommended treatments for patients with hematologic cancers? I think of it in 4 buckets: trust, awareness, clinical trial opportunities, and access to care. And you can pretty much read here on this slide, trust is definitely a big barrier. It could be cultural, it can be social, and a fear of mistreatment, historical stigmas, or like not trusting the provider. And so that's where trying to establish trust. People just might want to have a little bit more time to communicate with you, asking questions and feel comfortable in the encounter. Awareness of the disease, the risk, language fluency, these are all things that can be barriers to acceptable treatment in patients with disparities. Clinical trial opportunities, like I said, just ask. Don't assume that your patient might not want to participate in clinical trials. Try to explain to them the benefits, how it might be helping them, might be helping others. There also can be a bridge for the financial burden that they might be experiencing. For example, they might live 60 miles away, and you think, oh, they're not going to want to participate in a clinical trial, but a very well-designed clinical trial that might be sponsored by a pharmaceutical or another company, then they can get travel assistance, reimbursement for parking and other expenses, not coercing them, but giving them that opportunity to participate in that clinical trial. And then access to quality of care might be a barrier, too, that we need to overcome. So some solutions are highlighted here for the trust, awareness, clinical trial, and access to care. You can read these as well, but again, just really trying to communicate and access and establish trust, giving time for the patient and the caregiver to answer questions, explain to them why you think that this treatment is superior to other treatments out there, and having that conversation. Again, making sure that there's culturally appropriate communication in their language. That's one of the problems with the clinical trial participation is there might not be a consent form in their native language. So making sure that you're translating those consent forms, if you have a high Hispanic population or other Asian-speaking population, is important. Accessing to social workers, financial counselors, partnering with them in the communities is also important as well. Innovative ways to offset the medical costs of transportation back and forth to the appointments can happen. Like a lot of insurances will have a benefit for Uber or Lyft services. Like in Ohio, we have about 60 rides per year. Some of the insurances are allowing. And then our hospital does also have a patient fund based on benefactors where they can have transportation assistance as well. So in conclusion, disparities in blood cancer exist, and hopefully we as healthcare providers can help bridge and overcome those barriers and gaps in care and identify and intervene with some innovative strategies as well. Thank you. Did I get us back on time?
You did. Dr. Faiman, fantastic job. And thank you. Thank you. Marathon. Yes, great round of applause. Okay, so we're going to move on now to our next speaker. Is going to be Dr. William Dale from the City of Hope, talking about a very important topic for all of us as we treat our patients in our aging population. It's hematology and aging, tailoring treatment for older adults. Dr. Dale, thank you.
Thanks. For those of you who are hanging out, thank you for making it to the bitter end, and I'm glad you're all here. Some of the earlier talks, I think, are a nice setup, and I always remind myself in these circumstances that Lincoln did the Gettysburg Address in 2 minutes, and we still remember that one. So these are my disclosures, which I don't have any. I really like older people. The woman on your right over here was 112 years old when I took care of her. These last week, I had a 101-year-old who had 2 cancers that we're treating at City of Hope, and a 104-year-old we're also treating with surgery. So For those of you who are looking for places to treat these older patients, we're doing that at City of Hope. These are just a reminder. So I'm just going to give you some basic tools. So the way to take care of older patients is we saw there's all these barriers to care, all of what you just heard about with all the different groups that you described who don't have access. Most of them are older. When you look at clinical trials and you see who's enrolled in clinical trials, most of them are younger. The patients you have to treat in clinic, the majority of them are older. So your typical patient is an older patient who you're trying to treat with data from people who are younger, many of whom have had a lot of access barriers to get there. So what do you do with these patients is what I often get asked. And some version of a geriatric assessment is what you do. I'm not just going to tell you that. I'm going to show you the 2 large trials that just changed the treatment guidelines that are making this basically the standard of care. And I would encourage you to use the tools which we're trying to make available. So the essential tool is all those domains we just heard about that prevent people from having good outcomes is what's in these assessments. And we've spent a number of us many, many years trying to come up with the most concise, simple way to assess performance, function, cognition, psychology, nutrition, social support, all those things that are essential to treat patients that we basically don't assess very much at all in our clinics these days. So what does this look like? These are all in hematological illnesses. When you do screenings for patients who show up in any of our hematological clinics, these are the percentages that you will find who have deficits that are significant in these domains. You may be surprised, I know my colleagues often are, to see that a quarter of their patients will have cognitive issues that are unidentified. Patients that have 50% of them don't have social support that makes it possible for them to go through treatments. So when they get to us, they do very well, but getting to us is often the problem. So this is like the super fast primer on this. So we have a chemotherapy toxicity risk assessment tool available online at the MyCarg website that allows you to predict in advance of receiving chemotherapy grade 3 to 5 toxicities. If you use KPS to do this, you might as well just eyeball them because that's about how good KPS is at identifying those who are going to have toxicities after treatments. If we use this risk score with 12 factors in a scale from 0 to 19, you can give patients the pre-treatment likelihood of toxicities from 25 to close to 90%. I also showed the form that at the MyCarg website, you can go there, log in, it's free to the public. This is a real quick timeline, which you can see in the slides, of the 2 randomized trials in the ASCO update for how to take care of older adults with cancer, which we led from City of Hope. This is one of those trials called the GAIN trial, which reduced chemotherapy toxicity, increased advanced directives completion significantly. And what was done was a geriatric assessment was done prior to the trial, randomization, supportive care interventions were put in place afterwards, and both heme and non-heme toxicities were significantly reduced. This is the GAP trial published in Lancet. This is the exact same geriatric assessment that's up on the website, in which chemotherapy toxicity was lowered over 20%. Falls were reduced, medications were adjusted mostly to be decreased, and polypharmacy went down. The chance of getting reduced dose intensity went up, and the chance that your survival changed was not at all. So all you got was reductions in chemotherapy toxicities, less dosing of toxic medications, and the same amount of survival. And I would suggest that's a good intervention, and it would be a nice drug. It's not a drug, you just have to do the actions required. This is the framework we just heard about decision-making for older adults. This is also published in a JCO article in which you determine vulnerability using the geriatric assessment. Then you can predict toxicity risks, life expectancy, and targeted interventions. Then you can use that to tell people about their risks, overall benefits and risks, and guide your therapy appropriately to maximize according to their preferences, balancing quantity and quality of life. What are the barriers to GA use? So we did a big survey of about 1,200 oncologists and asked, why is this something that's so hard to do? On the left is what they told us in that study. On the right is one for transplant. And essentially people say these tools are great, we believe they work, but we don't know how to use them, we haven't been trained in how to use them, and we don't have the support to administer them in clinic. So our task has been to create for people an online available tool. This is the action chart from the ASCO guidelines that tells you exactly what the tools are, which have been boiled down into about a 10-minute assessment, the items that you should act on, what the cutoffs are, and what the intervention actions you should take would be. In a way to make this as straightforward and simple, but also bring this powerful tool to clinic. Most of this can be done not by oncologists. This could be done prior to clinic by other personnel in the clinic. We do it with online assessments, 2 small tests in the clinic with our medical assistants, which is then given in a digested form to our oncologists so they can add it into their discussion with patients. Now, shifting real quickly to heme malignancies. Age is associated with almost all of the heme malignancies in terms of a risk factor. As people get older, the chances that you'll have a heme malignancy go up. What is really helpful is as we expand these therapeutic options, as we heard about earlier, age is where that expansion is going to occur. There's a new tool. This is the tool specifically for transplant patients who are being considered. We saw the encouraging data about those over 70 with the availability of transplant possibilities or CAR-T. The CHARM study was just completed by the network, and these are the factors that ended up in the model for the CHARM tool. This paper has not yet been published, but has been presented at ASH. So there are lab tools, albumin and creatinine clearance, CRP, comorbidity index, a cognition tool, age, weight loss, and KPS were all entered into this CHARM model. What came out of this is that non-relapse mortality at 1 year was predicted by sorting using the CHARM tool, and overall survival at 1 year was also able to be sorted through use of the CHARM tool. It's available online, but you have to have the permissions so far, and they're about to make it more publicly available. I just wanted to remind people so they can reach out, and you'll be able to simply put in these values, and it'll tell you exactly what the non-relapse mortality estimate is at 1 year for patients over the age of 65. Very quickly, I wanted to just show you that we have a multidisciplinary clinic at City of Hope that uses geriatric assessment prior to stem cell transplantation for patients referred to us by our colleagues who are over the age of 60. I won't walk you through all of the details, but what I just described for you, we're able to put into our clinic with minimal disruption of the clinic flow in close collaboration with our colleagues. It allows us to sort patients into the proper places and to make one of 3 decisions for people. We are not in the business of telling people not to get transplants. So that is often the fear of people who show up, that they're coming to our clinic to hear that they've been ruled out for the possibility of transplantation. Most of them have come to us from other institutions that have said, essentially, you're this age and we don't transplant people who are over that age, which is really a discriminatory approach to patients who really should be transplanted based on fitness and the ability to complete the trial. And so we've tried to redress that difference. So what we say is, this is a healthy person who happens to be older, and they should be treated like every other patient who enters into transplantation. That's a go forth with the plan. At the other end of the spectrum, we say this is a very high-risk patient. Here is the risks of the toxicities that they'll experience. Here's the risks that they may even have a disease that will limit their life with a successful transplant or not, and you should be clear with the patient about those risks before you go forth. The middle category we call defer and optimize. So there's often something that can be corrected, which is the value of a geriatric assessment, because they are addressable, correctable problems. So you can defer the transplant for some time until people are optimized. And our outcomes have shown that we continue to have good outcomes, especially for this middle group of patients. And a couple of publications have documented this, and we recommend it for others and happy to share. So this is what happens in general. So over half the time, proceed is the answer. But with about 25% of the time, we do a defer and optimize, and the outcomes have been quite good after that. This one I'll keep in the slide deck, but really explains in more detail exactly the workflows that we've put in place that really maximize disease control, improve the resilience of the patients after they recover, and then tailor the platform so that we don't intervene on everything, but on those things that matter most for patients and that are correctable. We can't make them younger, but we can make them fitter in many cases to tolerate the treatments. Last two slides. I'm going to do mine in under 10 minutes, I think. So you guys can give me a round of applause for that piece. So we have funding to create infrastructure to help care for older adults across the country that combines our Rising Tide Foundation with what's called the Geriatric Oncology Treatment Optimization Program. We have collaborators across the country, as you can see in the lower left. Infrastructure on the right, I will highlight. This is an NIH infrastructure grant, an R33 grant that supports a analytics core, a measurement core, a supportive care core, communications, and analytics, along with a bunch of other things like this scoreboard that I mentioned. These are patient partners who are over 65 years old, who have survived cancer, who are close collaborators in all the work we do, so that patient input happens from the very beginning of all of our studies. We've had people come to our cores, which is available online, to join us and get advice. We've had 50% success rate that those who've come to us and have utilized our cores and getting grants, mostly NIH grants, from the input that we give. And we just had a number of R01s funded across our network. This is the Rising Tide studies I wanted to mention, the GO2 studies, highlighting our hematological CAR-T therapy study. 5 different randomized trials with the same geriatric assessments, which are going to give us answers to questions relevant to older adults for lung cancer, breast cancer, prostate cancer, and community-based cancers, along with our CAR-T therapies. These are all my friends who help us do all this work, many of whom I have close contacts with. I especially like Beverly, who's sort of in the middle, off to the left with me there. She's a 90-year-old African-American woman who's been a patient partner for many, many years, and has been instrumental in forming Scoreboard and making sure we have patient representation in everything we do. These are the answers to the questions. You guys will have to figure that out if you are doing your CMEs. And I'm finished. Thank you.
Thank you very much, Dr. Dale. So we made up a lot of time here, so we'll give everybody a quick bio break, get a beverage, go to the bathroom if you need to, and then we'll resume for our last portion of the programming, which will be a panel where we invite our participants back up on stage, and we really welcome any questions from the audience, whether in person or online. So if you're online, please send them in now, and we look forward to hearing them. Thank you.
All right, ladies and gentlemen, let's get started with our panel discussion. We have many of our esteemed faculty, and I invite you up to the stage. Dr. Alousi, I see you sitting there. And this is your chance, okay? This is what it's all about. We kept it small so that you can ask all these famous people some questions about what they've talked about. I've got some questions ready, but I'd really like to hear your questions. Dr. O'Donnell's there on the other end as well. So we'll kick it off. We also have some online questions that will go up, but let's start with the audience. Don't be shy. These guys are not so scary. Do you need an extra chair? There's an extra chair right here.
You know what? You have
Oh, there's one extra chair here.
the podium. There, I'll go sit.
There's an extra chair here.
Do we? No.
Oh, you can.
No, we're good. I'll stand on the podium.
You can. Steph, you want to take that? You want to take the podium? Sure. You take the podium mic.
too.
All right, we got it.
Oh, you can-
Everybody, how about it?
right.
This is empty.
Fantastic.
All right, so let's see. Anyone from the audience? Raise your hands, don't be shy. We got mics for you.
We can come out and find you.
All right, just to break the ice, let me get started with a question. We'll start with Dr. Jain. Dr. Jain, beautiful 2 talks on CLL and CAR T-cell therapy. I'd like to ask you something about CAR T-cell. You gave a really nice discussion about obe-cel and the new therapies. One thing I want to know about more is the use of MRD and how you use that to guide sort of a consolidation therapy, maintenance therapy, CAR T-cell, as well as the use of allogeneic stem cell transplant, or the indication for transplant in people who are MRD. And also use adaptive clonoSEQ as well as flow.
You're asking in the context of ALL.
ALL, sorry, yes.
So, so ALL, there's ample data that if you're MRD positive, whether it's by flow cytometry or by clonoSEQ or NGS MRD, there's a high chance of relapse if you don't act on it or do something about it. So in the context of CAR T-cell therapy, I guess the question is, if a patient is MRD positive, can you use CAR T-cell therapy
Right.
as a therapeutic approach? So prospectively, that is being studied now in several clinical trials. They have not been, they're still enrolling. But at our center, we have used in retrospect, in a real world setting, CAR T-cell therapy in patients with very low tumor burden, less than 5% blast. Some were flow MRD positive, some were clonoSEQ MRD positive, some were in fact clonoSEQ negative. And we have seen cell expansion on those patients. So I think, certainly I think CAR Ts would work in low tumor burden setting. Now, how low you need to go and whether there will be a threshold where maybe CAR Ts won't expand as much, I think that remains to be seen. I guess MRD post-CAR T, if you are day 28 post-ALL CAR T, for anyone like Zoma3, Brexucell, or obe-cel, and if you're MRD positive, or whether by clonoSEQ or flow, I think that's a very high risk of relapse. And I think those are the patients. You can wait, but I think these patients are not going to do very well, very likely going to relapse. And we really need to think of that as a potential disease relapse. And depending on what patient therapy patient has received previously, you may want to think about, adding the next salvage therapy.
All right, very. So just a quick highlight, just a quick high-yield question. If a person with ALL who is high risk at baseline is clonoSEQ negative, 0.0000, do you still send that patient to transplantation?
So, so that's a area of new research to see, so that's in our setting, I think if someone is SERF2, which is the high-risk marker, rearranged young patient, has a good donor, I personally would still, after CAR T, do a allo transplant. Though I think but on the other hand, if you, like if the MRD, sorry, I missed that, what was the question?
If you were to transplant the MRD positive.
Yeah, so I think that, I think you can salvage that. What was the patient scenario again? Sorry.
Just a high-risk patient.
Yeah, high-risk patient. So I think the question is if the other high-risk patient, for example, complex karyotype, P53 mutated, which are maybe high-risk in some settings, if they become clonoSEQ negative after using hyper-CVAD-based therapy, pediatric regimen, where you have now incorporated blinatumomab, maybe inotuzumab, and if they become clonoSEQ negative, I think it's quite possible for those patients you may not need transplant. But I think that's something we need to study prospectively because all the data that these are high-risk markers were derived from the era when we were using chemotherapy alone, like hyper-CVAD and augmented BFM regimen, pediatric regimen. Now that we're adding INO and Blina, as you know, has become now standard to be added to every regimen, adult and pediatric included, I think those high-risk markers need to be redefined, what remains still high-risk marker.
Good point.
And so I think that's, it will take some time because ALL, B-cell ALL is a rare disease, especially adult BLL. So I think it will take some time to generate that data.
Excellent. Any audience takers so far? Yes, sir.
So this is CLL, right, you're asking, right? Yeah, so one thing is that, MRD per se is not a criteria to treat CLL patients, right? So it's very different from ALL setting, as you know. So the recommendation, all the right now approved regimen, for example, venobinituzumab or venrituximab relapse setting, everyone is for 1 or 2 year duration. And in fact, the upcoming Acala-Ven regimen will also be a 1 year duration regimen. So if they are MRD positive when you're stopping therapy, one thing is clear, that if you're MRD positive, most of the data is with flow, but clonoSEQ included, those patients will have a shorter PFS. Makes sense. If you have active disease, still some remaining disease, this patient will have a shorter PFS. Now the question is, how can you intervene on MRD positive patients? What should you do? Should you extend the duration of treatment? Should I continue Acala and Ven 2 years? Should I add obinutuzumab at that time? Some data from our group and others have suggested that longer duration of therapy improves the PFS. We have done 2 years of ibrutinib venetoclax, and that improved the PFS at 5 years. But that is still not, kind of standard of care. So I do use MRD at the end of treatment to get that knowledge. If the patient is MRD negative by flow cytometry, I'll be very comfortable that maybe that patient will have a 5, 6, 7 year remission duration, and that's, on the flip side, if they're MRD positive, it's possible in the next 2 or 3 years that patient will relapse. Now, whether I'm going to act on the MRD at this time, depending on the regimen, I may continue it. So I have continued venetoclax longer for those patients, especially in the relapse setting, because then you're worried that the patient will relapse and they will not have very good options. But I think the MRD connotation in terms of CLL and ALL, which I was talking before, obviously very different, because CLL, if you're MRD positive CLL, you don't treat, in general, right? And that's not a recommendation at all. So I will treat it maybe in a part of a clinical trial, but in a routine practice, I would not recommend acting on it.
Okay, other questions?
So then that becomes a different thing. Then you have active disease, then you treat, but just MRD positive, normal counts, normal lymph nodes, practically no symptoms. These patients can go on for some years without needing treatment criteria.
Ma'am?
So with the new AV and AVO regimens coming, are we seeing patients needing inpatient treatments at the beginning of therapy for TLS, or are we kind of past that phase of things?
Yeah, so I think one of the things with the AV and AVO is that the first 2 months in the AV, for example, is acalabrutinib alone. So that the BTK inhibitors are very good in debulking strategies, and we and others have shown that 80 to 90% of high-risk tumor lysis syndrome or medium-risk tumor lysis syndrome become low risk at the end of 2 or 3 months of BTK inhibitor therapy. So you start a patient on day 1 on acalabrutinib, 2 months later you add venetoclax, but by that time their tumor bulk will be much decreased. So, I think the number of patients requiring hospitalization, because they're still high risk when you're starting venetoclax, I think will be less than 5%, probably like 1 or 2% range. So majority of these regimens will be outpatient regimen, in my opinion, for a majority of the patients.
Thank you.
Dr. O'Donnell?
Yeah, so I have a question for Dr. Yee. So you shared with us some good data from DREAM 7 and DREAM 8, specifically looking at belantamab mafodotin in combination with bortezomib and dexamethasone in comparison to daratumumab. But really, I think the bigger question when it comes to BCMA-directed therapy is, how do you think of this BCMA drug versus some of the others, the bispecifics and the CAR T cell, when you think about your recommendations for patients?
Right. So, well, thanks, Betsy, for the question. So this, when you have all these things to choose from, I mean, back, years ago, if you didn't have many choices, the decision was a lot easier. But now that we have all these different drugs to choose from, then the decision making gets a little bit more complicated. So, essentially, I mean, I guess it's a broader question, and this question comes up: do you pick an antibody-drug conjugate, belantamab mafodotin? Do you pick CAR T-cell therapy, or do you pick anti-BCMA bispecific antibodies? And a lot of it depends on what you have available to you. So I think if you go to a major medical center, here we have access to all those therapies available. So then it is kind of a decision. Whereas I think in the community, say if you live like 2 hours away, like you don't live like right next to MD Anderson or something like that. If you live like if you live in a more resource-limited area, you don't necessarily have all those therapies available. So then the choice for you may be more constrained by what's available to you. So I think all things being equal, I mean, just to answer the question rather than just dodging around and say, well, it depends. And blah, blah, blah. Okay, to answer the question, so if I see a patient who's had 4 prior lines of therapy, I think a lot of those times at that time, all those therapies, CAR T-cell therapy or a bispecific antibody will be available. And I think all things being equal, a patient at that time, after they've been through 4 prior lines of therapy, usually is kind of ready to try something completely different. And I think all things being, I think CAR T-cell therapy, what we see with the cell-to-cell data in terms of the PFS of 34.9 months, I think that is a high benchmark to clear. And I think, there'll never be a direct head-to-head comparison. So typically, if a patient has been through multiple lines of therapy, I typically would recommend a CAR T-cell therapy compared to a bispecific antibody. Now, granted, in the future, I think bispecific antibodies, you could probably augment the response further. They're looking combinations of anti-BCMA, anti-GPRC5D, then there's also trispecific, but I think that CAR T-cell therapies I would typically recommend a CAR T-cell therapy. This also gets into the sequencing as well, because we do know that, if you've had a prior bispecific antibody, that could theoretically compromise the efficacy of a subsequent CAR T-cell therapy. So, granted, this is really tiny, a small number of data, but people looked at patients who received an anti-BCMA bispecific antibody, then they had cilta-cel. And then in those patients, there's only like 7 patients. I think the PFS was like 5 months. Granted, there's probably some small numbers of patients and confounders, but there's that theoretical possibility. Now, another alternative, maybe you could do a talquetamab instead, and then you could do like a team up for a BCMA CAR T-cell therapy. Now, in terms of at the same time, these questions come up all the time when patients come to see me in clinic. At the same time, I also recognize that CAR T-cell therapy, it's a lot of work, right? In terms of, there's a lot of logistics involved in terms of, the patient has to get to the medical center and then they have to get the cells collected, and then you get to think about bridging, and then they have to stay around the area for around 30 days. They have to have a caregiver with them. So they have all these T's to cross and I's to dot. And not every patient has all that, or not every patient wants to go through all that. And I think for some patients, or many patients, I think the bispecific antibodies can work exceptionally well. I think for patients who have like a biochemical relapse, I think the bispecific antibodies can be a really great option for those patients. Now, then we get to, I think, belantamab vedotin. I think that, DREAM 7 and DREAM 8, granted, it has a movie behind it, right? But, okay, that was a joke. But I think in terms of, all things being equal, I keep using that. I have to come up with a different expression. I think the bispecific antibodies, when they work amazing when patients are really happy with them. And I think the infection risk that is generally a lot of concern, I think it's less of an issue in 2025. I think when they first came out, yes, there was really high infection, but personally, I'm just not seeing that degree of infection. And whereas the belantamab vedotin, I think the major limitation is the ocular toxicity. So I think personally, I think it's the bispecific antibody is an easier sell than belantamab vedotin. But I think if you're giving it out every 8 weeks, maybe you have to get an eye care professional. I think that these are all things in flux. So that was kind of a long-winded answer.
Well, thank you, Dr. E. Any questions from the audience, guys? Anything else? Bravery? Yes, ma'am.
I have a question also for Dr. E. You mentioned when you were talking about tocilizumab that some people are doing prophylaxis. Can you speak about that a bit more?
Right. So tocilizumab prophylaxis. So you saw that some of the initial data for 25 patients, the risk of CRS went down like 75% to maybe 25%. And then there was some data that was presented at ASH, University of Miami. It's only 14% total CRS. And now that's in the NCCN guidelines. Have we been doing that as now, those are just fresh off the press. So we haven't been doing that yet. And we have our own protocol where we're not using tocilizumab. So I think if you're able to, I think the major limitation, if it can be covered by insurance, why not? I think personally, it's probably a no-brainer to try it. If reimbursement's not an issue, I think I would totally explore that.
Do you know what the dosing is or when?
I think the dosing would be the same as the standard for the occurrence of CRS. I think it's 800. I've read off the top of the head, you know.
Great. Love the audience participation. Others? Sir.
I have a couple of questions about MPN. You practice at altitude, and I don't know what comments you might have in terms of a hematocrit threshold for patients who live at altitude. Some of our patients come from this altitude.
Yeah, thank you for that question. So the first question is an important one. The altitude does come up a lot. It comes up in clinic for patients who travel quite frequently, and especially here we are in Vail. I just pictured the board disassociation curve in my mind when you said that. So it is a real issue, and I'll tell you, it affects us in two ways. One is in the secondary or reactive workup, which I mentioned briefly. So there are 2-3 DPG abnormalities, and so it is a good one. It's not just a board question, but there are subgroups of patients, Chuvash region of Europe and others, Andean region, Tibet. So people who live at higher altitudes, you think they have PV, but it's actually a reactive thrombocytosis. And then there are also people who have von Hippel-Lindau and other, sort of gene family mutations that can have an erythrocytosis. So I think this is an important point. So differentiating secondary from primary. In patients who have PV, you're right, we still say below 45%, but actually we make caveats all the time, don't we? So sometimes for our female patients, we do below 42% hematocrit. Altitude, we make an exception. There's people who split their time, obviously you guys know here, half the time here, half the time at sea level. So you're right, I have to say, you're not gonna see it in a textbook, but we do make those changes. What was the second question you said?
It was about variant allele frequency.
Yeah. Yeah, so VAF, I've been talking about it for 20 years, since I was like an intern at Johns Hopkins. We envied CML, now even FLT3. Everybody is following allele burden. We were the last ones. But I did show one slide on this, and I'm glad you brought it up, because I want to make sure that's one take-home point for today. For the very first time, variant allele fraction matters. There are two classes of drugs, an interferon, so the Ro-Peg interferon, but even before that, in pegylated interferon, those studies showed a clear decrease in JAK2 allele burden, and even CALR as well. Not always correlating with outcomes, but often. And then in the MAGIC study by Claire Harrison, UK, that's the one that I want to focus on. That's ruxolitinib versus best available therapy. Hydroxyurea was the first one. And for the very first time, decrease in allele fraction correlated with EFS and overall survival improvement, and possibly even reduction in thrombotic events, all the things we care about. And this is something that caught everyone off guard. It's one of those things we've been saying for 20 years, and it finally showed that. I think 2 points, though, Dr. Kadia, would be one, who's really going to check allele burden in the real world, right? It costs money to do that. Who's going to really check that? This is not CML where we're following MMR and CMR. And two, we found that there are qualitative differences in reporting the allele burden. Dr. Dauber, you're one of the first people to note that in FLT3. Is it the allele burden? Is it, so actually people are reporting it differently. And then what are you going to do about it if it goes up? We're not making therapeutic decisions based on it. So I think both of your questions are super important practically, and they've come up for me in clinic in the last 6 months.
Okay, we have a question back here. Ma'am?
Hi, I wanted to kind of add on to that. So I work at even higher altitude than what you do.
Wow.
We're at, I work in Dillon, and then my patients are in Leadville, which is 10,000. So most of our patients, I do a JAK2, CALR, MPL, BCR-ABL testing all the time because we have to.
Yes,
it's just one of those things.
Well, that's interesting.
But then on top of that, too, the other side of it is with polycythemia, in this population at altitude, you do get blood clots, you do get chest pain, you do get vision changes and headaches. So I have to do phlebotomies on these guys, and I set it to 50% because there's no data on that. Tibet is the only paper I could find that actually looked at that.
That's what I was thinking of, right? Exactly.
So, and that's the only thing that's probably equivalent to living in Breckenridge and Vail and all these places. So I will say Denver's a little lower. Salida's like 7,500. So you get to know everybody and what their levels
How
will be.
about that? This is a great parole. And if I should add, I practice at sea level in Houston. But Joe Prakal,
I can barely breathe here.
But Joe Prakal in Utah, some of you may know him. He's one of the really great investigators in our field in MPN. He's in Salt Lake City now. He's done some of the studies you said. So he's taken the Johns Hopkins cohort in Baltimore, relatively at sea level, and compared to Salt Lake City. So it's exactly what both of you said, precisely what you said, both practically, but also they're looking at HIF-1 alpha, hypoxia, so there's a whole thing. And then I should also mention Prakal had an ASH plenary session this past year on exactly what we're talking about. He studied an Andean South American population who has exactly what you said, differential, and they found some EPOR gene variation. I just can't tell you how excited I am, both of you. We're going to take over this total. They had no idea what they signed up for when they had us here.
I mean, what we're hearing is there's probably a lot more polycythemia out here because of the altitude.
And
And
I
how do you
guess-
differentiate that? Go
I
ahead.
was going to say, I do have a second question with
Yeah.
it too. So one of the things, because I end up screening all these people, I find way more mutations than probably I should.
Wow.
Mostly because I screen everybody that comes in the clinic. I never did that when I was working in California. That was just not a thing, right? We
Right.
were a little more, I guess, reserved in ordering that stuff. What I have noticed also up here is I have a lot of CALR myelofibrosis
Yes.
in my clinic, and how best do you treat those? Because obviously, the JAK2 inhibitors don't work as well. We know that from some of the data. And I mean, I'm struggling because I'm having patients progress. What do I do?
Great. So CalAR, it's one of my new topic areas. I really love this area. So 3 things to say quickly. One is, by and large, the JAK inhibitors are working regardless of triple negative JAK2 CalAR MIPL, since they at least signal through the same ultimate pathway JAK-STAT. But as you mentioned, there are cases where it's not working as well. So I think that's important. 2, sometimes these CalRs will have inflated counts, so thrombocytosis, young people. I think that's great that you're picking those up. And then 3, we have these immunotherapies. So right now, they're in phase 1 therapy. I'm leading the J&J bispecific, for example. We have the Insight monoclonal antibody. Those 2 are fantastic treatments to give to someone who's had 1 prior therapy. It has to be a JAK inhibitor. And I'm moving those patients quickly to those clinical trials because they're designed exactly for these challenging patients. Before these 2, the monoclonal antibody and bispecific, we had a vaccine trial, which was either by itself or with ipilimumab, CTLA-4. But those results were not very exciting. That's why you don't hear about it. So I would say clinical trial, we have these trials open at multiple sites. And I have to tell you, you hit it spot on. Let's not treat, nobody else is treating their mutation patients the same. AML, they have mutation specific. So now we finally have that era. And then same thing for JAK2. So thanks for bringing that up. And by the way, thanks for checking, because if you didn't find those patients, nobody else would have, and they would have presented with a heart attack or stroke, so you're saving people's lives.
I have a question I have to ask, though, on this. So as someone who's raced the Leadville 100, that's a very,
Wow, whoa. Humble
so
brag.
qualified for it. And so sub 10 hour. Anyway, but so just saying. So I'm just curious, so who's your demographic? Because that's such a niche population up there in Leadville. Leadville's at 11.5, right? I mean, is it 10.5 or 11.5? 10, yeah, so it's high to start with. And so are you finding it in a different demographic? When I think of some of these are older individuals, but that's a somewhat young community. So I'm just curious.
So I have a handful that are like in their 30s and 40s. Those are my CALR myelofibrosis patients that I'm picking up. So I mean, I'm following them. They're currently not on treatment because they've been stable, but some are, I have like MF1 and MF2s.
Wow.
And that's why it's like, I know I've talked to some of the reps, they know, they're like, why do you have myelofibrosis patients? I was like, because I'm picking them up.
Right, 'cause
Then
you're looking
I'm
for it.
screening all of them, everybody comes in. And I will say, like, our primary cares are very good. They're like, oh, polycythemia, go see me. So they're very good about that because they don't want to manage
This is
that
great.
stuff. And we're the people who do the phlebotomies. But then the other side of it too is I do send them into iron deficiency. That's a fun one because I do so much phlebotomies up here. But yeah, so to speak to your point, people up here are healthy.
Young, fit
They're
people,
younger
right.
because you
Completely
can't.
different. Completely different demographic than what I'm
The
seeing.
people who do live in Leadville, Fairplay, Breckenridge, all these high altitude places, the oxygen levels do drop. And so usually that's self-limiting, right? So we are kind of like what we would call maybe a blue zone because these people live longer. But the people who do live up here tend to be, they tend to have to move once the oxygen issues happen. So they don't die up here. So we have great like life expectancy because the ones who do die up here are, you know, they're older.
You weed them out.
So,
We weed them
You weed out the.
but these are also the transplanters. I was going to say these are the transplanters that are 80. Like these are
Right.
those people because and that's what's hard to tell our patients is like, yeah, they're like they handle this stuff. They're really good at this stuff. And so as you were talking about, we shouldn't be doing just an age. That's this population.
Exactly.
It's a functional thing, yeah.
It's a-
There was a
yeah,
question up here in the front.
personalized, functional.
I have a question. I mean, earlier discussing polycythemia, secondary
Right.
polycythemia, and patient can be diagnosed with the JAK2 mutation,
Right,
not
both.
uncommon over here. But the question is, how much will you attribute a high altitude polycythemia in presence of JAK2 driver mutation? I mean, would that impact your hematocrit level? Because, you know, we have patient, I can tell you a lot of patients who are living, I think, 6 months, less than 6 months at high altitude, and then they go to sea level.
Right.
Very common Texas and Florida. We don't see a huge difference in their hematocrit if they are JAK2 positive.
Right. Yeah.
I mean, there's at most like 3%, 4% difference. It's not a huge difference.
Right. Yeah, no, I think it's a great, I think it's similar to what we're talking about. I still treat these patients as P-Vera. So if you have a JAK2 mutation, that is a driver mutation for the MPN. So unlike maybe other mutations, this is not a random bystander. So however you found the mutation, whether it's very nice screening, random, if you have JAK2 V617F, you do have an MPN. It may be masked PV, as you and I were talking about in the break. So the answer is you can have elements of both. You and I talked about, I've had a couple patients who have both obstructive sleep apnea and JAK2 PV. So even though I'm phlebotomizing them to the goal, they're still short of breath, symptomatic. Well, you're not wearing your sleep apnea mask at night. So you're having to treat simultaneous reasons through two different pathways of erythrocytosis. So the dogma that you can only have one or the other, either reactive or primary, is wrong. You can have both.
But Naveen, don't healthy people also have JAK2 potentially mutations?
So
I guess the point is, if you take 100 people living at a high altitude, and they will have some increased hematocrit, and you do JAK2 screening on them, how do you know that this is a pathognomic JAK2?
That's what you guys are asking.
That's
right?
what, and I don't know if you can.
So Dr. Dauber's right. So JAK2 is the 5th most common CHIP mutation. That's what you're talking about. Now, I wasn't even thinking about that, okay? I'm only thinking about MPN. So now you're introducing a very important element. That's what he's talking about. Okay, now you're talking. So you're saying bone marrow doesn't have morphologic. So this is a good point. There's JAK2 CHIP. It's the 5th most common CHIP. So after your DNMTA3, AXX01, TET2. So I think...
V617F?
Yeah. So it's JAK2 V617F. And the early, if you look at the Justwell New England Journal paper, Kalajian and others had a letter exactly what you guys are saying. But now the debate in our field is, are those people MPN to B? They're just hanging out. You happen to catch them early because of molecular. What's the morphology saying 6 months, 1 year, 2 years? Okay, so we can debate that. But I'll cede the point that you can have JAK2 V617F, but it is pathologic in some way. It's either CHIP if there's no morphologic, or it's pre-MPN or heading into MPN.
So basically, do the workup, check EPO levels, and then watch the person carefully.
This is another good reason to keep EPO level in the... Yes, please do a bone marrow, because then you can look for degree of fibrosis. Yeah, degree of fibrosis. You can send cytogenetics molecular a little bit easier. Rule out concomitant blood disorders or blood cancers. Absolutely do the bone marrow. It'll help you later on.
All right, I want to get some of the other panelists involved here. So
Go
Dr. Dale did a very nice and structured talk earlier about older patients in AML and in leukemia and in heme malignancies in general. So, William, if you don't mind, I'm going to piggyback on these two guys here, Dr. Dauber and Dr. Alousi. Dr. Dauber, just really quick highlight points of practical stuff for how we treat patients who are older with AML, which is the majority of the people that we see. How do you treat them with first frontline therapy, FLT3 inhibitor-based therapy, and now with these menin inhibitor-based therapy? And then when you're done quickly, Dr. Alousi, tell us a little bit about the prehab program when he's done with that. Go ahead.
And then Dr. Dale is going to
Dr. Dale.
Okay, okay.
I'll come back to you. Dale. I'll come back to you.
He's got the panel for the next 20 minutes.
Yeah. Guys first. I'm going to get everyone involved in the panel.
Okay, so I mean, I think I would start with saying what is older, right? AML. I would say today, and as you know, Dr. Kadia and many large academic centers, people above 60 today coming to us every week. We see many patients. We are thinking about the potential of lower intensity therapy. So I don't know if I call them older or not. It's an ageism thing. I just think that's low intensity therapy may be an option for those patients, especially if I find a targetable mutation, IDH, FLT3, maybe now the KMT2 NPM1, because we have these HMA ven plus potentially triplets emerging showing very good efficacy, where I don't feel the push to give intensive chemo like I did 10 years ago, because we're getting equal or better response rates. So I would say above 60, we're not using intensive chemo in general, except for somebody with a core binding factor, where you still have a very high cure rate, even in the 60 plus, NPM1 mutated, and maybe certain FLT3 with very proliferative features or other proliferative features where you need something. Everybody else, I'm thinking of a low intensity, whether it's HMA ven based, cladribine, low-dose RC ven, as you've nicely published, and potentially maybe adding a targeted therapy. I think FLT3 is where the data is most mature in this setting of adding a FLT3 inhibitor. Now we have a very good dose optimization regimen, how we can do it, still, I wouldn't say it's a full standard of care, but the data continues to grow, and I think there's more and more momentum towards doing that. HMA went with the FLT3 inhibitor. Menin, I think we're really early, but that is where the field wants to go quickly, especially since NPM1 is the founder mutation. The menin inhibitors are showing good activity. There may be less myelosuppression with menin. I say maybe, I'm not sure. We're starting to see some thrombocytopenia with revumenib, but I do think that's the direction the field is going to go. So, and then transplant, right? So the big question is, do you need to give intensive chemo if you're going to go to transplant? My answer would be no. And actually our group, including you, Dr. Short, and others, showed that when you take people above 60 and you look at the therapy, 3+7 or CLIA type intensive, HMA-ven or cladribine lorazepam, and those go to transplant, in fact, the outcome was best in those who went to transplant after lower intensity therapies. So it's not that intensive chemo has some special powerful response that the transplant only benefits after it. So then if I have a 60-year-old and I want to get them transplant and they have a FLT3, I prefer to just go with HMA-ven FLT3 and go to transplant, and there are randomized studies starting. So I'll kind of turn it here to Amin to
So
pick
we'll
up
move
the
to
baton.
transplant. And then Dr. Dale, what I want you to think about is, we as leukemia doctors, lymphoma doctors, myeloma doctors, we see these older patients. We often find we don't have the ability, the tools, the quick way of just saying, hey, how do we measure the fitness? You show beautiful tools, but to apply those tools in a clinic environment, so think about that. But Amin, tell us about prehab.
Sure. I mean, it's very similar to what Dr. Dale reported, at least what we do at MD Anderson, where these patients undergo comprehensive assessment, all the prognostic factors that Dr. Dale presented in his talk, including cognitive testing, nutritional assessments, biomarkers, functional status. We have rehab and PT and OT. And we're screening them for fitness, but more importantly, as Dr. Dale pointed out, we're screening them for modifiable factors. So we have our transplant pharmacists review their medications and look for, medications that commonly our patients are on that may pose problems in the post-transplant setting. Sedative meds, overlapping sedation, that's maybe less tolerated when they're going through the transplant process. Our rehab doctors and physical and occupational therapists have them engage in prehab exercises, which they continue through the transplant process and post-transplant process, and they're followed and tracked from their outpatient to the inpatient. We have our financial people look at some of the financial burdens that may be unique to this population. And so, again, really looking for those interventions more than just prognostic, but looking to see how you can improve outcomes in this population. But I'm sure Dr. Dale.
Dr. Dale, is there an app for that?
It's interesting that you sort of raise it that way. So we've moved into implementation science more than anything else. Like I'll immodestly say, we spent a lot of time figuring out what matters. And I think we know now what matters to get some patient-centered prognostic information to assist our hematology and oncology colleagues who are the experts on all the other stuff. But what we're having trouble with now is we are only treating the people who get to us, and I'm at City of Hope, and they don't all get to us. I can promise you that. But the people who get there get good results. So how do we actually bring what we do to them? And so we're doing telehealth-based reach out to Antelope Valley. So if you know where City of Hope is, that's 60 miles from us out in the middle of nowhere, essentially. And we get 95% patient satisfaction with essentially the same assessments I just showed by doing a telehealth intervention. So, so one answer is we need to understand that not just do it practically, but actually study implementation science. Can this be done? Does it actually work? Does it matter? I'm fascinated by this idea that we have people who are essentially functionally experiencing what old people experience because we now put them on mountains at the 10,000 feet where as a mountaineer I experience myself. I know what that feels like, right? But get away from age-based anything. Can we please get to some patient-centered fitness assessment that's integrated into the studies, which is the second part of what I'll say, and then I'll shut up. The trials, we are not doing these assessments, and we're not enrolling the patients who get the disease into the trials because it's too hard, we haven't figured it out, it doesn't fit in workflow, nobody wants to pay for it. That's not a criticism, it's just a reality of if we're gonna apply them later, and in post-treatment, we're like, oh my God, all this stuff is happening, no one knew it was gonna happen. I think we could avoid some of that if we had these simpler assessments up front. So my advertisement is, we'd love to work with you guys. I think it would help both of us to integrate all of this cool work.
But in all seriousness, is there an app or some sort of electronic that we can
Well,
quickly go through?
Yeah, I can't say there's an app, but I've been asked that a bunch of times. I will
Because it would
direct
be-
to the MyCarg website.
Yeah.
We're putting up every tool as we get them onto the website and trying to make them available.
That's great.
But I do need a little help in that getting them into the trials is a little hard. There's no support to get them into the trials, and we need help with that. I have boiled everything I do down to the smallest package, minimal effective dose that I know how to put it into. And I think that's fair on our part, but it's not magic. So people will tell me, what can I do in 2 minutes in clinic to figure out their cognitive impairment and functional status and their comorbidity? I can't. It's not magic. It's not pixie dust. I can't sprinkle it out there and figure it out, right? But I think we can, but we need a little bit of like partnership on that. So we're close. Please contact me. We need partners.
We're hearing you.
You know,
Okay, audience
I
questions,
was
yes.
going to add just I completely agree that I think age is a construct that somehow in AML has been stuck because of the 5 decades of 7+3, right? And I think it's up to us, and we are moving away quickly from it, because if you look at the outcomes, they're heavily driven by the molecular entity. So if you take a TP53, the person can be a 30-year-old marathon runner, and it can be a 65-year-old person in a wheelchair. Unfortunately, the outcome is the same, 6 to 8 months. And if you take a core binding factor, again, a 40-year-old and a 70-year-old can actually have very similar outcomes. So I think we're getting to that point where there are studies now looking at HMA ven versus intensive chemo, which hopefully will read out very soon. And I think if that study is equal, it doesn't have to be 3+7. At least I think me and many people I know overnight are going to be done with it. And so then we're going to be in a myeloma territory where you have a Rev, bortezomib, Dex. You have a backbone. It doesn't matter what your age is. You just have this backbone, and can you build on it? And I think that is where we need to be in AML, because I agree, we have to do this because the regulators want it today. They want to cut off in Viale of 75. Then they say it's 60. But I think if we make it like they've done in CLL, like they've done in ALL, it doesn't matter what your age is. You have Philadelphia positive, you get blinapontinib, 20, 80, 60, it doesn't matter. I think this is where AML is going to go now, molecularly driven.
Thank you. Dr. Akhtar.
Disease status before transplant. So I want to see how you guys work at Sage Center when it comes to deciding when the right time for transplant.
Dr. Alousi.
What's that standard?
The right time for me. The right time for me is always yesterday.
Yeah, I think that's a question for Alousi, because we know what our right time is. I mean, go ahead. Quickly.
Well, how do we do it? Well, certainly upfront, seeing these patients very early and getting the donor search process, that's important. But how do we know when's the right time is a balance between our leukemia colleagues and this conversation.
I mean,
but
are you looking for MR? My point
Are
is
we using MRD
status.
assessment?
How does it affect your decision? That's
no. The short answer is no. I mean, if somebody is MRD positive or MRD negative and they're a transplant candidate, we're probably going to take both of those. And there's, as you're, I'm sure, aware, data to support that approach.
So I want to see how much you push to get deeper.
So this is, it's as Amin knows, and it's getting more nuanced. So there are certain molecular subsets where even the decision, should we transplant or not, every week we discuss a lot in our group, Dr. Kadia, myself, others, and those are NPM1 FLT3, because now that we have access very recently to this ultra-sensitive 10⁻⁻⁶, I call it like the AK clonoSEQ of AML, which is now showing in publications very strong predictive 90% survival. If I have a 63, 64-year-old borderline fit and I get an NPM1 molecular MRD negative in 2 cycles of intensive chemo, and the donor is 9 on 10, 10 on 10, do I want to push? Do we want to push? We may say, no, in this setting, this person may have more risk than benefit. Same is happening for FLT3. And then for maintenance, post-transplant, we're still starting to think about the pre-transplant molecular clearance, especially for FLT3. But outside of those two subsets, and there may be for KMT2A a PCR coming very soon, we've been working with in vivo scribe. I agree with what Amin is saying. We plan to give 2 to 3 cycles. That's the time it takes to achieve all the logistics and all that. By then they're in remission. If the MRD is a low-level positive and the transplant is ready, we would probably not change our course. We may say, I'll give some maintenance, other things post-transplant. But yeah, we're not using it to, because I've heard from many other centers, which is why I think earlier their question is that they're saying if you're not MRD negative, we won't transplant. And then we see a lot of those patients relapse, and then they come to us in a relapsed high-risk situation where the window may be lost many times, yeah.
Okay. Dr. O'Donnell?
These are all great questions, but I wanted to bring Dr. Angelos into the conversation for inclusive. One of the things that most excited me today was talking about gene therapies. I, started my fellowship in 2010, and there was not a lot that was available for patients with sickle cell. And so what you talked about today was particularly exciting to me because I think it's really revolutionary. And so one of the questions that Andrew and I were discussing is why is the focus on hemoglobin F and producing more of that and not fixing, editing to fix or correct the underlying hemoglobinopathy? So maybe you could just tell us a little bit about that.
Yeah, for sure. So this has actually been looked at, initially trying to just repair the very well-known characteristic mutation that causes adult hemoglobin to be misformed and then sickle disease. It didn't work too well when they tried to do that. And it really is dependent on the cells having very clear homologous recombination as opposed to non-homologous end joining to occur. And that was not just robustly occurring every time utilizing a CRISPR-Cas9 technique. So that really wasn't a good option. And
with the newer technology now, would that change?
Well, so with the newer technologies, with the base editing approaches, the sickle mutation is not amenable with that particular technology because it's a single nucleotide change. And it either has to be an A to G or a C to T repair, which is just not the case for the sickle mutation. Now, to the other end here, using an upstream enhancer region which controls the downstream regulation of hemoglobin F, which we know when it's increased, just like hydroxyurea does, when it's increased, it causes these cells to unsickle and prevent the sickling from happening. If there's a mutation within that enhancer region, it now becomes a much more versatile therapy. This area in the enhancer region is actually a non-coding region as well, so it's much more easier to edit that area, and it's also an easier place to get a very high efficiency edit. And so that's really why these companies have targeted in on this enhancer region, because it's a lot easier to edit that area. You're functionally getting what you need, which is hemoglobin F at the end of the day. And it now turns into a more universal therapy. So it's not only just for sickle cell, but it's also for beta thalassemia, right? Where there's also issues with the adult globin genes, either having loss of particular exons, multiple copies that are lost, things like that. So it becomes kind of a trifold answer. It's easier to edit, it's much more reliably edited, and then it also is a much more universal approach. So that's why that one particular adult mutation hasn't been caught on just yet.
Yeah, Dr. Angelo, I found your talk fabulous. I mean, it was my favorite, I think, because it was like, it's science fiction, but now it's reality.
It really is, yeah.
It's really like these people are getting cured of sickle cell disease.
Yeah.
So my question to you is, along the same side as Dr. O'Donnell, is if we can do this with sickle cell disease, why are we not looking closer at cancer? Why not take a person who has a hematopoietic stem cell that has a P53 mutation, say, bye-bye, or a MECON rearrangement and just CRISPR that thing?
Yeah, or JAK2, right?
Or JAK2.
Exactly. Yeah.
Yeah. What's the obstacle? What are the challenges?
Yeah, I think the biggest challenges are making sure that you're having the right technology, right, that's going to be able to hit each one of these particular mutations. You have to be able to kind of be at the right place at the right time for having the right machinery to very reliably correct these pathogenic mutations over and over and over, right? And so we're starting to do a little bit more of this with some of the, and I'm certainly not an expert in this area, but some of these inborn metabolic diseases, like PKU and like other types of issues. There are these single point mutations that are in fact targetable for gene therapy. And so disease groups outside of hematology are now starting to get more on board with these gene editing approaches. Same thing with like CAR T cells, right? CAR T used to just live in the hemoc space for many years when it was first coming about. Now we're seeing a lot of groups that are using it for lupus nephritis.
Oh, yeah.
Neurological disorders that are autoimmune based. And so more and more physicians outside of, our specialty are starting to use this technology. And I think, groups are becoming a little bit more comfortable in administering preparative chemotherapy regimens as well. At least at our center, we have multiple trials that are open in the autoimmune space, the neurology space, the renal space, and we partner with our colleagues in these divisions to safely administer preparative chemotherapy and then also the cellular therapy that can target these clones that are causing those non-cancerous diseases. So I think really the field is moving quite rapidly in these diseases that are outside of the oncology space, and it's really exciting. I mean, just think about bone marrow transplant, right? I mean, when bone marrow transplant first came around, that was science fiction too,
Yeah,
right?
you're right.
So
You're right.
I think we're still kind of coming.
One point I was going to say, a lot of what you're saying though are deficiencies, right? Where you have a loss and you are able to produce it. Is there an example of successfully suppressing an overproduction? Because that's the problem in cancer, which at least I have very little knowledge. From what I've heard from others is much, much harder to suppress multiple clones. And do you think the same technology will be done, or do you think, what do we need to do? Because I think it's very different, no?
Yeah, it certainly is. And I don't know if I have a good answer for that question for sure. It kind of is. I mean, if you think about just the biology of cancer, there's a lot of like feedback loops and things that really just converge on a common pathway. And so it can be very difficult to kind of target a lot of these different things that are all upstream that really kind of converge on one gene or one protein. So it's definitely an interesting thought, especially with the TP53 mutated disease. TP53 mutations come in a lot of different flavors, point mutations, biallelic loss. So it's very difficult to really generate a universal strategy for each one of those specific mutations. But certainly I think we could start to chip away at particular subsets and maybe make an impact.
Great, thanks. Any last questions, comments from the audience? Yes, ma'am.
So one of the things as a community oncologist, you get these cytopenias that come in, and how do you work these up? And where do you go from here? Kind of the rule of thumb from my training was, you have 2 cell lines down, you do a bone marrow. But I know that as we're getting into the more specifics of like myeloid NGS panels and things like that, how does that direct you guys? I know what I'm doing in clinic, but I want to hear what you guys are doing on when these patients perhaps, and maybe they're not coming to you, maybe it's the community physicians and then you guys at that point, but like, are you seeing more community oncologists doing testing for myeloid NGS panels, utilizing that to determine should we be doing a bone marrow on this one cell line down individual to help decision making?
I mean, I think there's a lot that goes into it, right? I mean, it could be one cell line down, but there are other clues. They've already had the iron studies, they've had the scopes, they've had other testing, rheumatologic, that suggests that this is not a non-malignant issue. And so in those cases, even if it's a single cell line, I'll go take a look. If it's thrombocytopenia, maybe I might empirically treat them with steroids or IVIG to see if it's ITP. But if I don't see anything like that, I may go beyond and do the bone marrow. I mean, to be fair with us, the people that we get referred to us, because we're so specialized, we sort of do bone marrows in a lot of these people right up front when they come in. But I mean, I think it's a good rule of thumb if you do have a single cytopenia, monocytopenia. If it's anemia, obviously rule out all the anemia causes. If it's thrombocytopenia, maybe empirically treat them with ITP. Neutropenia is interesting. I see a lot of those. They often tend to be a lot of LGLs. So a low-grade LGL, they have no infections. They have ANC of 0.6, 0.7. You can do a peripheral blood flow for T-cell CD8 positive T cells, and you can do TCR alpha and beta rearrangements in the peripheral blood, get monoclonal, and then you know what it is. And so I think that certainly 2 cytopenias, we're more likely to do it, but even monocytopenias, if there's everything else has been ruled out, we go to the bone marrow pretty quick. I don't know, anyone else?
Yeah, I was gonna, and the other side of it is we are definitely seeing a lot of patients referred to us with TP53 chip, TP53 CCUS, coming in. So I've had like 3 or 4 coming through the transplant department. They're referred for transplant saying, I have TP53, 18%, sent to transplant, right? Normal counts or like hemoglobin of 10.5 or something. And it's tricky because everybody's nervous about TP53, but we've generally not transplanted them. We've followed those patients because even with a single TP53 chip, the hit rate, the conversion rate is very low. It's actually 5% or so. In fact, some of the other chips have a higher penetrance rate, IDH and others. So we're seeing a lot of this noise, but I think it's okay because through this, we will eventually come up with formulas to say, okay, if you have such and such mutation And it's not going to be a single time point. There's a physician, Paresh Vyas in UK, who's developing models for kinetic changes in these mutations. We're probably going to be able to predict if the TP53 changes by this much over 6 months, 1 year, 18 months, then this person has an 80% risk of TP53 MDS AML. You may need to do a preemptive transplant, like they do preemptive colectomies and breast surgeries for certain patients. So we're not there yet, but we're starting to see a lot of these referrals, and I think we'll eventually get there. Yeah.
Similar to treating
Les, yeah,
smoldering
Les.
myeloma.
Yeah, exactly.
Yeah. Quick question.
Can I ask a question, Dr. Pemmaraju, about CML? Now, asciminib is approved frontline for those patients that are on it and they get resistant to it up front. What would you? What's the?
Does that happen?
Okay. Well, I abstain from this question. So, can you? So you're talking about if you haven't given ponatinib yet, right?
Right. Now, asciminib is frontline approved, right? So, like a big gun for upfront that if they lose their response, then I would just say ponatinib.
I think if they're naive to every other TKI, if they haven't had
TKI
a traditional TKI, I think they'll still be sensitive. Dr. Cortes showed you that among the patients who have asciminib, there is, there's these high IC50s for other mutations.
So that's what I was trying
But if
to.
you look
so
across,
what is there any recommendation? Like just
So-
go with ponatinib or look at
Dasatinib
that?
probably should be is just as good. If you actually look at the IC50s, they actually overlap. It's almost like if you could combine both of them, you would have very few resistant mutations, at least the ones we know about. So I think you can use it as a guide. I typically use dasatinib or ponatinib as my next line of therapy.
I mean, I think that would be a good person to just do the Abel kinase mutation profile,
That's
right?
true.
And then if
That's
you have
true.
an E299 or a V5, then choose. But if not, I think, yeah, rule of thumb, if you want a more powerful TKI,
But
there's
most
no
of the time,
mutation.
those mutations are not really all the time in that table that you're looking for. So.
Right. Then I think ponatinib, I mean, Dr. Gantarjan has said this a lot, and he's obviously studied CML tremendously. If you look at the potency of these drugs, preclinically and even clinically, ponatinib is the most potent still today. So I think if you're in a pinch and you're failing a TKI and there's no mutation, and you want to go to the more powerful drug and the patient is young and healthy, I think ponatinib is still the best
The
bet.
chances are, if they're only resistant to asciminib, which is a completely different allosteric site, they'll likely be sensitive to most of the traditional TKIs. One more last question. That's it.
I just had a question about a young patient who are MDS positive but not high risk. I mean, you are not sure about CHIP in those patients. Like macrocytosis or very mild cytopenias. When do you decide to check for telomere instability? Do you check it on all patients, or there is some type of mutation you should be looking for?
Yeah, we're not doing it that much. I think I don't really do it frequently. We have a hereditary leukemia clinic. Dr. Leonardo will refer. I think it's in people who are either really young with MDS, 40, 45 or below, or have a family history. But if I have somebody like 70 with macrocytosis and a mild CHIP CCUS, I'm not like thinking about telomerase and that, but I don't know other.
Yeah, so I think typically if they're under 50 and they have MDS, I usually do all that testing, genomic testing, and telomere length testing. The genes you want to look for telomere, the TERK, and all the telomerase sort of associated genes. Some of them are included in the 81 gene panel, as well as some of the commercial panels that are available. Others, you have to actually go to a genetics counselor that does all the non-common sort of TERK mutation sequences. But it's usually TERK, it's DKCs, just keratosis congenita. The other one is Fanconi's, usually 40s, have MDS for no reason. They have maybe some family history. They have some, more morphologic, either short stature, extra fingers or toes. Those patients usually have double-stranded DNA break repair defects, and it's the Fang genes you want to check. So you can do like what they call a diaboxybutane assay. It's very quick and dirty. If they have easy chromosomal breakage, they typically have some sort of DNA repair defect, and then you go and do the genetic studies. But for usually it's those young people that we typically look at. But I want to kind of wrap up here, unless there's some burning questions. I really want to thank you all for staying. I think you've been a great audience. Thanks for trudging all the way up here to Vail, Colorado. I want to thank Madison back there and her Total Health team. And then I want to thank my co-host, Dr. O'Donnell. I'm gonna hand it over to her.
Listen, I want to also thank all the people who sponsored this event. I want to thank all of the physicians, panelists as well. And I get the best part of the day. I get to announce the lottery winner. So, Julie Elliott, congratulations. You have won our raffle. Yeah. As our winner, please stop by the registration table to pick up your parting gift. All right, thank you all. Have a wonderful day and safe
Panelists, for
travels.
staying.